live on Facebook. We're live on Instagram. And welcome, podcast listeners. This is the PT on Ice Daily Show, brought to you by the Institute of Clinical Excellence. My name is Dustin Jones. I'm one of two lead faculty within our older adult division, teaching modern management of the older adult, essential foundations, advanced concepts, and then live as well. Good morning, y'all, in here. And today is Wednesday. It is Hump Day. Hump Day Hustle just went out. Just looked through that real quick before I hopped on. Jeff Musgrave, good morning, sir. Y'all need to check out this email. I mean, in terms of the variety of links, but the variety of checks to our biases that we talk a lot about on this on the podcast, the PT on Ice Daily Show. I greatly appreciate everyone sharing different articles that really challenge a lot of the things that we talk about, and we're going to talk about one of those articles that really checks our biases around high intensity training, definitely strength training, in relation to pain, in relation to knee osteoarthritis. The title of today's episode is Intense Strength Training Does Not Ease Knee Pain. Intense strength training does not ease knee pain. Before we hop into today's episode, I do want to mention we got a bunch of courses that are going to be kicking off within the next couple of weeks. Almost every single online course is going to be kicking up in March. So Modern Management of the Older Adult Essential Foundations is going to be starting next Wednesday. We only have 3 or 4 seats left based on the last time I checked. And then almost every other online course is going to be firing up. So if you want to get in those online cohorts, be sure to do so. And we're going to be pretty busy through March and April with our live courses as well. PTOnIce.com is where you can get all that information. So intense strength training does not ease knee pain. This is taken verbatim from the title of a New York Times article. Some of you all may have seen this. It was published, I believe it was this week, basically talking about this study that came out in JAMA. So the title of the actual study is The Effect of High Intensity Strength Training on Knee Pain and Knee Joint Compressive Forces Among Adults with Knee Osteoarthritis. This is the START, S-T-A-R-T, randomized clinical trial. Kelly Benfey, happy belated birthday. She's on watching Instagram right now. And so this New York Times article, anytime, I don't know how y'all feel, but anytime that I see New York Times or a big outlet cover some new research, I typically am very cautious. I'm typically, okay, this is a study I need to read because I'm not necessarily going to rely on the interpretation of this media outlet that is driven by attention and getting clicks. So they can often make rather dramatic claims and false claims, honestly, sometimes based on some of this research. I wouldn't say that's the case with this New York Times article. It's a good read and was a good critique of some of this evidence, but I think it's helpful for us to be able to apply this study and the results in our practice and working with individuals that do have knee OA. Because if you just read this, at surface level, you're thinking, oh, well, why should I even load these individuals that have knee osteoarthritis if it didn't improve their pain or joint compressive forces? So we're going to dive into this. For those watching on the video, I'm going to be looking at my screen to make sure I get all these numbers and stats right to make sure we're good to go. For the listeners, this is not going to be boring. I'm not just going to be reading verbatim, so stick with me here. Probably going to be longer than 15 minutes. I'm going to do my best here, but I want to make sure we give this study justice because it was an awesome study of how they formed this and what they were actually measuring. I would love digging into this. So I want to dig in deep, but then also zoom out and be able to apply what this data actually means for us that are working with people that are in somewhat challenging and a lot of variable situations. All right, so their objective, quote unquote, does high intensity strength training reduce knee pain and knee joint compressive forces more than low intensity strength training and more than attention control in patients with knee OA? So this was done down in Wake Forest in Winston-Salem, North Carolina. Fun fact, Wake Forest is in Winston-Salem. There's also a Wake Forest, North Carolina. They're about 2 hours apart. I learned that one the hard way. They had 377 individuals in this study. So here's what these folks, here's the people that were included. They were over 50 years old. They had a BMI of 20 to 45, so overweight to obese. I'm not going to get into the issues with BMI, but that's what they used. These folks had a self-reported disability due to knee OA, and what they used was the WOMAC, I believe the Western Ontario McMaster University's Osteoarthritis Index, WOMAC. Pretty common, right? But they used just the pain part of the WOMAC. The WOMAC can look at pain, it can look at physical function, disability, but they really focus just on the pain piece, or the Likert version of the WOMAC. And what that basically is, I'll post a link in the comments of the Facebook video, is it asks them, how does your knee OA impact your ability to perform different activities? And so it's 0 to 4, 0 being it doesn't impact me whatsoever, and then 4 is it impacts me extremely, in an extreme manner. And so the issue with that is that all of these people that were included in this study had at least a 4 or more. So that could have been they just ranked 1 on a few different ones, or they could have ranked a 4 on one, to where they were highly irritable, that they were highly impacted by their knee OA or perceived knee OA and these different activities. The interesting part is, across the different groups, their average was about 7. So 7 out of 20. And so that could have been, these people could have been relatively highly irritable. Keep that in mind, all right? They also had visible osteoarthritis based on x-ray. They had neutral alignment of their knee or lower extremity, which they kind of categorize that of -2 degrees of valgus to 10 degrees of varus is what they determined as appropriate. And then no participation in formal strength training more than 30 minutes a week in the past 6 months. So that's who is in this study. More white men than females, over 50 years old, overweight to obese. They've got some knee pain on board. Some could be super irritable. Some could have kind of the generalized aches and pains. They didn't have too dramatic of some type of alignment issue that we can often see with folks that have knee OA, and they're not performing any strength training in the past 6 months. That's who we're working with. I know many of y'all are saying that's who I'm actually seeing in the clinic. So here's what they did. They took those 377 folks and put them into 3 groups. So these groups there were 2 exercise arm groups and then a control group. And I'll put control in quotation marks. That was the interesting part about this study. The exercise group was high intensity strength training and then low intensity strength training. Now these 2 groups, they did the same exercises. They did the same exact thing, except they were using a different dosage. And so it was 3 times a week, roughly about an hour session. After their 4th session, where they were focusing on kind of technique and introducing people to these different movements, aka these different machines, they tested their 1 rep max at week 4. And then they worked off of percentages of their 1 rep max for subsequent 9-week blocks after that. The duration of this training was 18 months, which is pretty cool. Pretty lengthy study, 18 months of this type of training. Hopefully we're going to see some pretty good results, right? We'll see. So what they did is they had a gradual progression of the intensity. So weeks 3 to 4, they did 3 sets of 8 at 80% 1 rep max. Weeks 5 to 6, they did 3 sets of 6 at 85% of their 1 rep max. And then weeks 7 through 8, they did 3 sets of 4 at 90% of their 1 rep max. Week 9, they retested their 1 rep max, and they used that new 1 rep max to dose accordingly over that 18-month period. They also leveraged RPE to make sure that these folks during the sessions were hitting their RPE of at least between a 5 and an 8. Now the lower extremity or lower intensity group, they did the exact same thing, except their dosage was 3 sets of 15, and they were working in that 30 to 40% range of their 1 rep max, and their RPE was a 2 to a 4. Same exercise. Now what exercise did they do? They basically used a bunch of Nautilus machines, if you will. They did unilateral, for lower extremity, unilateral hip abduction, adduction, a leg curl, knee extension, a leg press, and then a seated calf raise. For upper extremities, they did a seated row, vertical chest press, back extension, and then abdominal flexion. So this was in a group setting, and from what I could gather, it was basically seemed like circuit training, if you will. You're going to spend a certain amount of time on this machine, and then we're going to rotate. But it was kind of a group setting, but I wouldn't say it's a traditional, like a group CrossFit class, for example. Now, the interesting part here is the attention control group. Control in quotation marks. So what they did is they had 24 sessions over this 18-month period, a group educational counseling session, basically, where They got people together. They focus on adherence and self-efficacy with these folks. So they use social cognitive theories to discuss different strategies to improve adherence to healthy lifestyle behaviors, and then also targeting their self-efficacy or confidence in a particular activity. And they talked about things like foot care. They talked about things like nutrition. They talked about things like medications, sleep, these lifestyle behaviors that if you've spent any amount of time on this podcast, you know those are going to influence people in a positive way if they're able to execute. Lindsay Huey, good morning. I'm going to mention Lindsay Huey here in a little bit. So that was the attention control group. Not much of a control, right? The reason they use that is because in previous studies, the control group didn't show much change. All right. So those are the groups of people. Now, what did they actually measure? They measured that WOMAC. So the Likart version of the WOMAC, 0 to 20 scale, mainly looking at disability caused by knee OA pain. They also measured joint compressive forces during ambulation. They had secondary outcomes as well. So the primary outcomes were the joint compressive forces and the pain. The secondary outcomes were X-ray, 6-minute walk test, thigh muscle volume, an inflammatory marker, interleukin or IL-6 is a pretty common one you'll see when folks are looking at just kind of global inflammation. Knee extensor strength and then hip abductor strength. Those were their secondary outcomes. All right, that's a lot. Take it in there. Deep breath. Let's look at the results. All right, so this is where it gets really interesting. So their primary results, the WOMAC scores were not statistically significantly different between all three groups. All three. A little bit of improvement, but there is no significant difference between all three groups, between high intensity training, between low intensity training, and between control. All three groups saw some improvement, and there wasn't much of a difference between all those. Same thing for their joint compressive forces through their knee. Same exact thing. Now, secondary results, all right, the exercise group, both of them got stronger with the knee flexion and knee extension. All groups reduced their medication intake, their NSAIDs, significantly. All groups, not just exercise, not just the control, but all groups reduced their amount of NSAIDs that they took. And across all groups, there was no difference in 6-minute walk test, muscle volume, X-ray, joint space, or those inflammatory markers. So, sounds underwhelming, right? When you hear that, you know, a lot of us, I'll speak for myself. I was expecting, man, high intensity training is just going to freaking crush everyone else. It's going to justify a lot of my biases. This is going to be awesome. But then you go into the results and look at the data. There wasn't a huge difference, and all three of them improved somewhat, and there wasn't much of a change. So their conclusion, quote unquote, among patients with knee OA, high intensity training compared with low intensity training or attention control did not significantly reduce knee pain or knee joint compressive forces at 18 months. The findings do not support the use of high intensity training over low intensity training or an attention control in adults with knee OA. That last sentence is where they lost me. They lost me on that last sentence. So, awesome article. I encourage you all to read this. I'm going to post links in the Facebook group. Now let's kind of digest this and apply it to our situations working with folks. I've got 3 main points here. I'm already at 9:13. This is probably going to be over 20 minutes. Sorry, I'm not sorry about that. This is a really good article. I want to give it justice. I think the first thing to put into context for many of us that are working with folks that had knee osteoarthritis, whether you are in a clinical setting or even whether you're mainly in a fitness realm, this is not PT version 2.0 that we talk about. When we talk about PT version 2.0, we talk about leveraging, manual therapy techniques, being psychologically informed and being fitness forward. We talk about managing symptoms to maximize fitness. And this study was not that whatsoever. Keep in mind, when I mentioned initially, the inclusion criteria was that these people had over 4 out of 20 on their WOMAC. The average with all of these groups was a 7 out of 20. So what that could have been is either they all had mild symptoms with different activities, or they could be highly irritable in 1 or 2 activities. And that is very significant to think about, especially in the context of what we do or what we see when working with these individuals, especially if our goal is to manage symptoms to maximize fitness. One way that we're going to manage symptoms and to maximize fitness is with exercise, right? Exercise is such a potent drug that we can leverage in a very potent way. But with exercise, shout out to Lindsay Huey and Jeff Moore as well, the dose makes the poison. The dose makes the poison. If you have not heard that phrase before, Lindsay Huey did a PT on Ice episode about this, and I would look that up in the PT on Ice Daily Show archives, is that we have different stages in terms of dosage, right? If we kind of undershoot things, we've likely underdosed someone, they're not going to get much of an impact. We could overdose someone, right? And maybe cause irritability or some type of issue. But then there's kind of that sweet spot in the middle where we're acknowledging people's irritability, but then we're also giving them the positive adaptations that we know exercise can do. And what this study failed to do, just by the nature of evidence-based practice, is that it really falls short, because we're applying blanket protocols, very solid, consistent protocols, to people that are not necessarily consistent, to people that are on the roller coaster of NEOA and having symptoms with NEOA. And it's very difficult to apply this high intensity and even low intensity strength training, honestly, with folks that may have that roller coaster of NEOA. Because if we're honest with ourselves, what does most NEOA look like? You may come in on Monday and they're freaking crushing it, right? You load them up, you're checking their symptoms, making sure that you're good, you're not spiking up any irritability. And then come Wednesday or Thursday, they may have had a bad day, or there may have been a weather change, in quotations, that they may have a higher level of irritability. So what are you going to do? Are you going to stick with what you did on Monday, the same dosage? No, you're gonna use that symptom behavior model to see kind of how they're responding to activities, and you're likely going to change things like the intensity, maybe even the variation of the exercise, maybe even the range of motion of that activity, respecting the behavior of their symptoms. And a study like this cannot do that very well. What this study really was is, what is high intensity strength training going to do in a group fitness model with these individuals that may be relatively irritable? It wasn't PT version 2.0. And I think that's where we really need to have this in context. If we leverage a symptom behavior model, if we are managing symptoms as we're maximizing fitness, we're likely going to see some different results here. And we're likely going to see some improvements in a relatively quicker period of time. And that's rather challenging, right? Because we can't make these blanket statements. But I think all of us here that are working with these folks, that it's up and down, up and down, up and down, we're constantly modifying our programs and what we're trying to do. And that's okay. And that's what we want to do. We want to lead in that direction of progression and really making things appropriately challenging for folks. But sometimes we're going to have to knock it down a good bit based on how they're responding. So that's the first thing. This is not PT version 2.0. They were not able to manage symptoms as they're maximizing fitness, if you will. They were just focusing on that strength training. The second thing is, we want to see the forest from the trees. We want to see the forest from the trees. It's very easy to look at these results. And then also, once you read the New York Times review of this, is that, these three groups, no one really stuck out, right? High intensity, low intensity, the control group, the attention control group, they all got a little bit better, but they weren't that different. It's easy to say, all right, strength training is not going to be that important for folks with NEOA. And that could not be further from the truth. We have to see the forest from the trees. In terms of pain and joint compressive forces, we want to get people stronger in a way that respects their irritability, that symptom behavior model. But think about the benefits outside of pain and joint compressive forces for folks that are going to get stronger. When we're talking about improving their strength, their mobility, their bone mineral density, maybe moving them towards more robust than frail, maybe helping them not live their lives at 1 rep max, maybe being able to reduce their risk of mortality or occurrence of different chronic diseases, or decreasing their risk of disability. Strength training is still a very potent drug that we want to leverage. All right, so let's see the forest from the trees here. It's still going to impact people in a dramatic way. That's why we want to manage symptoms, but we want to freaking maximize their fitness, especially in folks in this study. Because you can literally alter the trajectory of their life if you maximize their fitness, and what we know that could impact things going forward for them. That's huge. We have to see the forest from the trees. Third thing, what can help, or what, think about this. The big surprise out of all of this was the attention control group, honestly, because the attention control group improved in a lot of these measures alongside the exercisers. And it was supposed to be control, but it was not a control group. They had targeted social cognitive interventions targeting people's adherence and self-efficacy around lifestyle behaviors. And that seemed to be relatively effective. Now think about what can happen if you take that framework and then combine that with appropriately dosed exercise. My goodness, we're likely going to see a significant change. And that's what the authors of this study said is their next thing. After this study and these results, okay, let's combine the exercise and this attention control group and see what we got here. And that's what I'm super excited about, because that's PT version 2.0 in some sense, right? When we're talking about these lifestyle behavior changes, we are the PTs that are going to talk about nutrition, sleep, foot care, all these lifestyle behaviors on top of getting people brutally strong. That is our game. Also managing their symptoms to maximize fitness. That's going to be awesome, and I cannot wait to see that. So I'm at 21 minutes here. I'm sorry, y'all. I'm not sorry. I'm not going to apologize, but this is a great read. I would read this. There's a lot to learn. I didn't dive into critiquing the specific exercises because, we have we have a bias towards some things like a deadlift, squats, whatever. They use Nautilus machines. I don't want to pick that apart. I don't think that's the biggest issue with this study. I think we just need to really take this information, put it in context of the people that we're working with. And I think we can learn a lot here, that the control group, man, the lifestyle modifications, we really want to emphasize that. But we also want to be very clear that if people may be irritable, that we're not just going to give them blanket protocols. We are going to try and load them up appropriately, but we are managing symptoms as we're maximizing their fitness. That's PT version 2.0. That is the symptom behavior model at its finest. And you just can't do that in a study like this. And we acknowledge that. So I'd love your all's thoughts. If you read this, let me know. What other critiques did you have? I know Alex Germano read this as well. She had some strong feelings. I'd love to hear Alex's thoughts. Whoever, drop that either in the Instagram comments or on the Facebook thread as well. On the Facebook video, I'm going to post all the links that I mentioned. So y'all can check that out. I think that's it. All right, 22 minutes in. I appreciate y'all being patient and listening all the way through. Get on that Hump Day Hustle. I mentioned that before. This article is linked in that email, along with a couple other things that will check some biases and be a good resource for y'all. Y'all can get that at ptonice.com. Go to the Hump Day Hustle tab on that site. All right, y'all have a lovely Wednesday. Enough of me rambling. I appreciate y'all. I'll talk to you soon.
Hey, thanks for tuning in to the PT on Ice Daily Show. If you enjoyed this content, head on over to iTunes and leave us a review. And be sure to check us out on Facebook and Instagram at the Institute of Clinical Excellence. If you're interested in getting plugged into more ICE content on a weekly basis while earning CEUs from home, check out our virtual ICE online mentorship program at ptonice.com. While you're there, sign up for our Hump Day Hustling newsletter for a free email every Wednesday morning with our top 5 research articles and social media posts that we think are worth reading. Head over to ptonice.com and scroll to the bottom of the page to sign up.